Awesome. Okay, thanks everyone for coming to today's talk. This is installment number 3 for our intern summer series. I'm so excited to have Dr. Prutkin here giving us an amazing talk on tachyarrhythmias. I just wanted to say thank you so much to Dr. Prudkin. He is an EP cardiologist working at University of Washington, making time for us in between cases, it sounds like. So thank you so much for your expertise and take it away.
Yeah. Thanks, Emily, for inviting me. Thanks, Ken, also. I've been doing this for almost 15 years now, giving this talk. And I feel like it's a big honor to be able to address you guys in the beginning of your training. And so it's one I've always really enjoyed doing. And it's not going to be just about tachy. We are going to talk about bradyarrhythmias also, because you will be called about those. All right. I only disclosure is I get some money royalties from Up to Date. All right. So what do you do if you're called from an arrhythmia? Here's about an arrhythmia. Here's the very basic thing. If someone calls you, and usually these patients will be on telemetry, look at the telemetry yourself, unless it's like a code and you got to run there right away. But make sure that you're looking at it, that you agree with it, especially if it's a floor where there are teletechs. The teletechs are really good throughout our system. I learn from them at times and we're able to give feedback from them. I find them really good. So talk to the teletech if it's one of those floors. And then if the arrhythmia is sustained, please get an EKG because this way we have it documented and we have it documented with 12 different leads, which is different than what you can get with telemetry. But don't get an EKG if there's no pulse. Call a code, do ACL. It's important to recognize that. All right, so I'm going to start with how to approach an EKG and really go at the basics of this here. This is the same way that I learned as a medical student, and I still teach this way, which is I just eyeball it first. I just quickly look around and just try and get a sense of like, does it look normal or abnormal? And then I go through and I do all those steps of what's the rate, what's the rhythm, what's the axis, what are the intervals like, what do the P waves look like, what do the QRSs look like, what do the ST and T waves look like? And then I describe and diagnose. So the difference between description and diagnose would be something like it's an irregular narrow complex tachycardia with ST elevations in leads 2, 3 in AVF and ST depressions in leads 1 in AVL. And then you diagnose it and say that it looks like it's AFib with RVR and an inferior STEMI or something like that. And it's really important to look at every lead and to look at the entire 10-second strip. Don't try and miss something on either end, and really to go through and look at every lead. And as you're thinking about arrhythmias, the first thing is, do you have calipers? Now, I know we keep a lot of things in our pocket, and we actually don't keep as many things in our pockets as we used to 20 years ago because everything's on our phone nowadays. However, I still have my calipers, and I still use these a lot. But I would start with that. And then the questions are there P waves? So if there's not P waves, is it because they have sinus arrest? Is it because they have AFib or whatever it is? And then are the P waves and QRS complexes regular? So do they march out with your calipers? Are the QRS complexes narrow complex or are they wide? Because that's going to help you with your differential of what's going on. And then are there more P waves than QRSs, which you might see with atrial flutter, atrial tachycardia? Are the P waves and QRS amounts equal? Or are there more QRS complexes than P waves, which is almost always ventricular tachycardia? And then the last thing is there a constant relationship between the P waves and QRS complexes? Essentially, is the PR interval constant or does it change, which may make you think about Wenckebach and may make you think about certain types of SVT and things like that. So those are the questions I'm asking myself. Basically, narrow complex, wide complex, regular or irregular. And I'm going to try and use those things to create the framework for approaching my arrhythmias. So when we think about the tachyarrhythmias first, okay, and I just went over this, I said, is it narrow, wide, is it regular, irregular? And then you can put everything into boxes when you do that. And the regular narrow complex tachycardia is by far the most common. It's going to be sinus tachycardia. But atrial flutter and SVT will also be these regular narrow complex tachycardias. If it's an irregular narrow complex tachycardia, by far the most common one is going to be atrial fibrillation, AFib. You can have other ones, multifocal atrial tachycardia, frequent PACs, and some other things. But really, it's going to be AFib is by far your most common one. If you have a regular wide complex tachycardia, the most common thing is going to be VT, although AVRT, which is one of those types of SVT in people who have Wolff-Parkinson White can look at, but that's pretty unusual. It's pretty rare that you guys would ever see that in your time. The other thing would be if someone has a bundle branch block or has some other reason that their complex is wide at baseline, they may have, let's say, sinus tach that with a bundle branch block. And so that would be a regular wide complex tachycardia. But then the worst ones are the irregular wide complex tachycardia. So those are things like polymorphic VT or VF, or some of those other things, again, if you have a bundle branch block with AFib. So this is, again, the framework by which I approach all my arrhythmias. Narrow, wide, regular, irregular. If you're going to have one of your take-home points, that's one of the take-home points that I would have for you, is break it down into one of those 4 boxes to help you figure out what's going on. So the narrow complex tachycardia. So we're going to do some polls here, which hopefully we have figured out. I'm sure Emily did because she's really good with this. So if you have a 73-year-old who is admitted with pneumonia and they report acute onset of shortness of breath and they have this EKG, so the question is, what does this EKG show? And for those of you who have your own computer, or if there's one person who chooses from the group rooms here, maybe we can answer that.
Yeah, we have people voting, so I think it's working.
Okay,
I'll give
good.
them a couple seconds.
Great. I just voted, so, and I hope I got it right. But we'll see here what we get. All right, and we'll see. I'll put up the question here again with looking like this. Is this sinus, AFib, flutter, or atrial tachycardia? All right, Emily, what do we got?
All right, I think hopefully you can see the results, but it's
Yeah,
88% say AFib.
I can see. So 88% thought that this was AFib, 8% thought flutter, and 4% AT. So this is AFib. All right, so great. That was a really great job, all of you. So just breaking this down into the way I said it before, again, just sort of eyeballing it. First thing I see when I look at this is the rate is irregular. So I look at that and the first thing in my mind is, all right, it can't be normal. All right, and then I go through that whole thing of rate, rhythm, axis, and all of those things. And when you do that, the key findings here is it is irregular, it is narrow complex, and there are no clear P waves. So I'm not seeing anything that shows clear P waves. I'm not showing anything that to me would look like flutter, where I'm seeing a repeated pattern of the same flutter wave over and over again. And when you see that flutter wave, that sawtooth pattern, that's going to be in 2, 3, and AVF. So I'm not seeing this here. I'm seeing an irregular, narrow, complex. I'm not sure how tachycardic it is, but narrow, complex rhythm that is doesn't have any clear P waves. So this is AFib. All right, let's do a second case. So this is a 61-year-old who presents to the ED with palpitations. Heart rate is 155, blood pressure is normal, and they have this EKG. And we're going to do another poll here again. And so what does this EKG show? Does it show sinus tachycardia? Does it show AFib, atrial flutter, and atrial tachycardia? Most of my questions are in alphabetical order to try and not give away anything. I guess I made a mistake that sinus tach should have been the bottom here. But we'll give you a little time here to figure it out. All right, Emily, you want to close it up? All right, good. We got a smattering of things, but not AFib. So really good. So this is not AFib, and it's tough to tell. It is a narrow complex tachycardia, and it is regular. And so when you put that in your box, that was in the top right box before, sinus tach is a possibility. Atrial flutter is a possibility. SVT is a possibility. And when I look at this, I'm looking at this and saying, gosh, 150 beats a minute, 155 is what it was, but things that are about 150 beats a minute are often atrial flutter. Doesn't have to be, but it's often atrial flutter with 2-to-1 conduction. So 2 flutter waves for 1 ventricular response, and that the second flutter wave is often buried within the QRS complex. So when I look at this, I'm saying, gosh, this ST segment and the T waves, like they're downsloping-ish and they're inverted here. It's a little tough to tell. I couldn't definitively say this, but I'd be suspicious that what I'm seeing is atrial flutter and that this is a flutter wave that's occurring in the inferior leads in that ST segment. But you can't say for sure with something like this at this rate. So you got to do things that would slow it down in some way. Right? So if you can give metoprolol, give diltiazem, give adenosine if you're not sure what's going on, then you might get a period where it's much more obvious. So now when you have a slower heart rate like you see here, now there's 4-to-1 conduction, and you have 4 flutter waves here in the inferior leads for every QRS complex. So this is hopefully to you a little bit more clear that it's definitely not AFib, which we didn't think it was anyway. It's definitely not sinus tach. Could this be an atrial tach? Yeah, it's possible, except for the fact that usually with atrial tach, you have isoelectric or flat periods in between the P waves, and here the electrical signal is continuously going. So this is atrial flutter. It's typical atrial flutter that we're seeing here. All right, so how do you, if you're called in the middle of the night, how do you manage someone like this? So the first question is always, are they hemodynamically stable? Is their blood pressure okay? All right, and if they're having hypotension, at what level is it? And are they having symptoms associated with it, like acute heart failure, mental status changes, ischemic symptoms, angina symptoms? And if so, if their, blood pressure that they've gone in and it's now 50/30 or something pretty significantly low, then you want to get anesthesia involved and cardiovert the person. But hopefully you're calling cardiology or you're attending or whoever else it is to help out this situation. So if someone is hemodynamically unstable, treat it like a code situation and cardiovert them. But please, please, please do not cardiovert someone who is awake and talking to you because it is really painful. So make sure you're getting anesthesia involved to help you with the sedation of them. All right, so if they're stable, then what do you do? All right, and most times, especially in the hospital setting, people will spontaneously convert within 24 hours. So really the question is, do you need to do anything or not? Right? And there's really this sense in medicine, like something happened, I have to do something and respond to it. But that's not always necessarily true. So if you have someone whose heart rate is rapid, or if they're having symptoms, you want to try and do something in that scenario. And really, if they're asymptomatic, the goal heart rate would be less than 110 beats per minute. So that's sort of, again, how you would define rapid is 110 more or less. And if there's symptoms, again, asymptomatic, again, you do want to do something about it. But if let's say their heart rate is 80, they have a history of paroxysmal AFib already, they're not noticing it, I personally would leave them alone. And I wouldn't worry about it and just be like, okay, that's good to know. Let's get an EKG to document it. But I probably wouldn't do anything more than that. One of my big, big, big things is please don't check a troponin unless they're having symptoms that are making you think they're having an MI or an acute coronary syndrome, ACS. Okay, we get these like spurious troponins all the time. And then like they may be just a smidge elevated, and then you got to figure out what to do, which usually is like, well, then you're going to go down a road of doing a stress test or doing a coronary CTA. And it's just like, you don't need to do it. You only check troponins if you're having a concern they're having an acute coronary syndrome, or I guess a PE also, it might be useful. But in general, please do not check a troponin in the absence of symptoms of acute coronary syndrome just because they go into AFib. All right, so how do we typically treat it? If you do need to do something about it, IV diltiazem is the first line thing for most of the time. If their blood pressure can tolerate it, I would do the 20 milligram IV dose in the beginning, but if their blood pressure is a little soft, maybe you want to start with 5 milligrams. And then you would start a drip somewhere typically at 5, but you can titrate it up to 20 milligrams an hour. That's usually the first line thing that you would do if you need to do something, just because you can give diltiazem on the floor and they don't need to be in the unit. So it's a lot easier to use diltiazem. You can give a few doses of metoprolol instead, but it doesn't last forever, and it's sort of a bridge to something else if you're going to be doing some IV metoprolol pushes. And then you can do PO options. And then depending on what the comorbidities are or what your comfort level is, you can use diltiazem as sort of a common one to do. Verapamil we use less commonly. It's got a little more blood pressure lowering effect. Metoprolol you can use. We use a lot of that. Atenolol. Digoxin doesn't have a huge role in this scenario, or it's just because digoxin usually takes a few days to really get full effect. We know digoxin, you have to check levels, which can become an issue, and you really want to shoot for the lower end of the range to be therapeutic. And it's just sort of a little bit of a pain in the neck. It also doesn't work great for people who have any sort of energy level capacity. It works for best for people who are pretty sedentary. Rhythm control. So there is the occasional person where you say, I want to try and get them out of AFib. And so amiodarone we use a lot of around here. You can give a 150 IV bolus and then you can put them on a drip. It's really best if someone has a central line while you're using it. Some of the floors don't even let you give IV amiodarone peripherally. You can see in that picture there, someone who got IV amiodarone peripherally, and then they got an infiltration of the IV, and it was really painful and tender for them. I don't want to get into the details of anticoagulation because we don't have time in this talk today. Besides saying if you're attempting a rhythm control strategy, the person should probably be on anticoagulation, whether it's with heparin, warfarin, or one of the DOACs. And then there's the occasional situation where we might be using flecainide or propafenone or ibutylide to convert someone, or a cardioversion. But if you're getting to that point, you should be calling cardiology to get our involvement. Sinus tachycardia. So this is a 30-year-old who's admitted with shortness of breath and they have a heart rate of 175 beats a minute. This is worrisome, right? Like, why is a 30-year-old or why is anyone coming in with sinus tachycardia? So this is one of the more concerning arrhythmias, potentially, is that someone has sinus tach. And so then you have to go through, and this is just a partial list. This is not a complete list of all of the causes of sinus tachycardia, right? Anything from fever and infection to hypovolemia. They could be in shock, anemia, anxiety, PE, and you can read this list. But if someone is coming in with sinus tachycardia, you really want to try and figure out why it is and see if it's representing something that is potentially life-threatening or not. So in general, if someone has sinus tachycardia, you don't want to treat the heart rate itself. You want to treat whatever the underlying cause is. Why are they sinus tachycardic? And then treat that. The one situation where I would say, look, we do want to treat it would be if someone is having sinus tachycardia in the setting of an acute MI, and then you want to give beta blocker, right? You want to reduce the myocardial oxygen demand in that situation. So you want to give beta blockers for that. But otherwise, if someone's sinus tachycardic, figure out what's going on. Don't give them beta blockers. Treat whatever that other thing is. All right, case 3. So a 63-year-old is admitted with chest pain to 5 Northeast. And while waiting for a stress test, he reports an abrupt onset of palpitations and mild chest discomfort to his nurse. And his pulse is 150 and blood pressure is 132/88. And this is the EKG. I think I had another poll associated with this one. We'll put that up. Great, thank you, Emily. So what do you want to do? Do you want to cry? Do you want to call your senior resident? Do you want to give adenosine? Do you want to give metoprolol? Or do you want to do all of the above? Okay, let's close it up. Great. I love it. It's pretty much equal amounts for each. I think I'll go with all of the above. I think it's fine to cry. I cried as an intern more than once. It's tough. You're tired. You don't know what you're doing, it feels like, at least especially in the beginning of the year, but it gets better. If you don't know what you're doing at any point, please ask for help, right? Whether that's your senior, you're attending a consult, whatever it is. I think in this situation, it's reasonable to give adenosine, or I think it's reasonable to give metoprolol. But I'll say what we did here. So I'll just go back to this and say, so what is this? This is a regular narrow complex tachycardia. And it was abrupt onset, so it's less likely to be sinus tachycardia. But is this flutter? Is this SVT? It's sort of tough to tell. There are ST depressions relatively diffusely here. So it does get me a little bit concerned, and I don't want to just leave this person in this heart rhythm for too long. So we did give adenosine for this person. And one of the keys when you give adenosine is, assuming you have the time and it's not some sort of emergency situation, hook them up to a 12 lead EKG, hit the rhythm strip button, and just let the rhythm strip print out. At the very least, make sure they're on telemetry, because you may say you saw something and I am not going to believe you as the cardiology or electrophysiology attending. I need to see the printout. I need to see documentation over whatever the response is. Okay. So in this case, the person got a push of adenosine and their ventricular rate started to slow down. And I've showed you with the arrows there are P waves that are marching through. With some QRSs that you get there also. And if we extended the strip out further and not just the little bit you can see here, and we went for 2-3 pages later, what you would see also is that he went back into a 1-to-1 rhythm. So there are P waves and no QRS complexes. This was an atrial tachycardia for him, made a focal AT. It's not very common, to be honest. This is probably 5 to 10% of SVTs is something like this. But we gave adenosine and we got our answer, at least diagnostically. Won't help us therapeutically because now you got to figure out, can I give metoprolol, diltiazem, or whatever it is. Here's another example of another SVT. So this is a narrow complex tachycardia. It is regular. And in this case, you can see P waves. You can see P waves here in lead V1, and I'm hoping my mouse is visible. But it sort of gives you this pseudo R prime type appearance, which is characteristic of AVNRT. But in this situation, again, you could give adenosine to see what happens. And when you give adenosine and someone has either AVNRT or AVRT, then it typically will terminate the tachycardia, assuming you give enough of a dose. So that's the difference here between what we saw in the prior one is now it terminated it. You have a few sinus beats, and then you get a few P waves and no QRS complexes because you got heart block. And then it kicks back in again as you move along within a few seconds. So if you have someone who has SVT, the first things you can do, again, get an EKG of it, hook them up to a rhythm strip, make sure they're in telemetry also, and then you can do vagal maneuvers. So you can have them do the Valsalva maneuver. Valsalva maneuver works best if they're laying on their back. It can work a little better if you have them with their legs up a little bit. You can also do carotid sinus massage. So you can listen to the neck first, make sure there's no bruits. And then a firm pulse for 5 to 10 seconds on one side and then the other side. If it hasn't broken with the first one, don't do both sides at the same time. We do not recommend doing ocular compression anymore because we don't want to break the globe, which is a really bad thing. Yeah, exactly, Ken. But that's happened in the past that people have had orbital fractures from, I don't know if fracture is the right term, whatever it is, but they've broken their eyeball if you push too hard. So don't do that. Adenosine. So if someone has a central line or a PICC line, something like that, that's a better option to push it through that. But you can give 6 milligrams, 12 milligrams, give a very rapid saline flush as you're doing it. Tell the patient ahead of time what it or what it's going to feel like, which is it's going to feel like they're dying for about 5 to 10 seconds, and then they will feel better. So please make sure that you know that or tell them that. You can get beta blockers or calcium channel blockers also, and that'll just sort of help slow things down and may or may not help terminate it. And then you can cardivert if it's really a big problem. I see questions in the chat here because I do have it open about how do you differentiate atrial tachycardia from atrial flutter. The short answer is it doesn't really matter from your point of view. The sort of longer answer is the easiest way to differentiate it would be if there is a P wave and then is it flat? And then you have another P wave, or is there continuous electrical signal? So is the electrical signal in the atrium continuously going, which is more consistent with flutter, or is there P wave, isoelectric, P wave, isoelectric? And that tells you that it is more likely atrial tachycardia versus atrial flutter. Of course, there's always exceptions, and a lot of the what are called atypical flutters can have that isoelectric segment also. So for most situations, it's probably not that important trying to differentiate the two. All right. Next one. So this is two patients who have the same diagnosis. These are the top one here is a telemetry strip, which has two different leads. The second one is essentially, or the bottom one is essentially V1. The top one here is essentially lead 2. And then on the bottom one here, this is an EKG strip, and the bottom line here is a pulse ox. So based on what you're seeing here, is this artifact, is this atrial flutter, is this atrial tachycardia, or is this ventricular tachycardia? All right, Emily. All right, to the 52% of you, great work. It's a tough one, but honestly, this is one that I get consulted on a fair amount. But both of these are artifacts. So if we look at the top one here, I think, let me just see. I'll go back here. So someone is going along, it's sinus rhythm. There are P waves, QRS complexes, T waves. And then P wave, QRS complex, and all of a sudden you start to see something here. And the QRS marches through at the same rate. So it's pretty unusual to go into an arrhythmia and still have the QRS complexes march out. Also, whatever this thing is pretty narrow complex, right? Usually you would expect some sort of flutter wave or something to be much wider, if it's truly that. And they look different over time, especially on this bottom row here. Like you start to get where they get a little lower complex or lower height. And then they start to become a little irregular by your time you're getting here. So it'd just be really weird to think there's some sort of atrial arrhythmia going on where the P waves are starting to change their morphology and that they're that rapid, but the QRS complex doesn't change. So this is someone like who's brushing their teeth or develops a tremor at that moment in time, or someone is, rubbing their body or whatever it is. On the bottom thing here, really the key to me is the pulse ox. Right, so to think that this is VT, but you're getting this pattern of the pulse ox still here, which is giving you a heart rate, that would be really, really, really unusual to get a VT where pulse ox is looking like this. And if you look closely, there is a QRS complex, a QRS complex, a QRS complex, a QRS complex. So you can see the QRS marching through here in a regular pattern. And because you have your calipers that we discussed earlier, you are able to see those QRS complexes marching through. But when you get something like this, use whatever information you have available to you and not just the EKG. Use your pulse ox. If they're in a unit and they have an arterial line, use that. If they have a swan, use that. Whatever it is, but use that other information to help you figure it out. But artifact is something that is relatively common. All right, let's get to the Y complex tachycardia. So a 35-year-old with a history of non-ischemic cardiomyopathy presents with palpitations. And this is the EKG. All right, and I'll help you out this time, and I'm going to tell you this is a regular wide complex tachycardia. So what is this? Is this AFib? Is this flutter? Is this sinus tach? Is this SVT? Or is this VT? All right, let's close it up. Good, good. So this is VT. All right, so the first thing sort of to be thinking about is just what's their substrate. And this person has a non-ischemic cardiomyopathy that I told you. So that sort of pretest probability Bayesian thinking is going to make you think it's a little bit more likely that this is going to be ventricular tachycardia. And even though the heart rate is 114 beats per minute, you can still have ventricular tachycardia that's super slow. We even have people that will have VT at like 90 beats a minute, where it's not even tachycardic anymore. It's AIVR, accelerated idioventricular rhythm. But one of the keys here, and I've given you the positive arrow sign, so hopefully your eyeballs are going to look at that, is I'm pointing to P waves. All right, so if you look closely, here it is, we have AV dissociation, and there are more QRS complexes than P waves. And that's one of the things that makes you think that it is much more likely that this is VT than SVT. And this isn't going to be flutter or atrial tachycardia or something because there's more QRS complexes than P waves. The other thing that will help point this out and give you a little bit more thought that this is VT is that all the QRS complexes are negative in V1 to V6. So there's this term precordial concordance, negative precordial concordance technically here. So the precordium are the leads that are V1 to V6 are called the precordial EKG leads. Concordance, meaning that they are all in the same direction and they're all negative. So if you see them all negative in V1 to V6 or all positive in V1 to V6, that makes it more likely that it's VT. If you see some sort of transition, like it's negative and then becomes positive, that doesn't help you as much. There are some other features that you can sometimes see that would make it more likely that is VT versus SVT. So I've circled here for you a fusion beat. So it looks a little different than all the other beats, that it's a little narrower. And that's because there happens to be a sinus beat that's coming down the His-Purkinje system at the same time that you're getting a VT beat. So you sort of have like half of a narrow complex sinus beat that just happens to be popping in during VT, and it gives you this fused EKG. Again, in this situation, like this VT is super fast, right? I don't know, this is like 250 beats a minute or so, give or take. And the person is stable enough. They're stable enough to be able to get a 12 lead EKG. So you can still have really fast rhythms and they're not coding. Now, hopefully you're checking in with the patient. You see what the blood pressure is, you're seeing how they're feeling, and maybe you're calling a code team, but you can still get a 12 lead in this situation. Okay. And in this situation, the QRS complexes are all positive in the inferior leads, and that's another thing that makes you think that it's VT. And all positive, all negative, and whether there's a transition has to do with where the VT is coming from in the heart. So what do you do in that situation? All right, so the first question is, are they hemodynamically unstable? Again, what's their blood pressure? Call a code if they're unstable. All right, shock the patient if you need to. But if they're hemodynamically stable, if their blood pressure is okay, please do not shock an awake patient. Right, I'm sort of going to emphasize that again. All right, it is uncomfortable. Don't use your hemodynamics to diagnose. So don't use your blood pressure to say, all right, it has to be SVT because they have a normal blood pressure. All right, call cardiology. You can give amiodarone. You can give lidocaine. We'll sometimes, if they're storming, give propranolol versus other beta blockers. There's sometimes people will use Impellas, which are these axial flow pumps. We'll get balloon pumps, ECMO. Some people we have to intubate and paralyze, but we're involved in those situations. All right, what do you do if someone's having a lot of PVCs? Well, you can get a 12 lead, and here's just someone who's in bigeminy. Most times, if you have someone who's having a lot of PVCs in the middle of the night, you can do nothing if they're asymptomatic. If they're symptomatic, you can try a beta blocker or a calcium channel blocker. Verapamil is probably better than diltiazem. If they're symptomatic, especially if it's like 2 a.m. and you're called, you're going to want to do something because like you're getting called and you're like, well, they're having PVCs. I'm worried that someone's going to like tell me in the morning I didn't do anything about it. I should at least do something. So let's check labs, even though they're going to be normal, but at least you felt like you did something. Most times if someone's asymptomatic, like, can you turn off telemetry? Because they probably don't need it. Because we have way too many people on telemetry that don't need it in the hospital. But you can never turn off telemetry on people. We've tried. All right, we're going to switch to bradycardias. Sinus bradycardia. So here it is. There is a P wave for every QRS complex. It's a one-to-one relationship. It's less than 50 to 60 beats a minute. Some people have a definition of 50. Some people have 60 for bradycardia. So this is sinus bradycardia. Sometimes you will have Wenckebach or type 1 second-degree AV block. And in this situation, if we look at the bottom row here, the PR interval is short, longer, 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 gets to be very long, and then you have a dropped beat. I typically don't look at all of these beats. All I care about is what is the PR interval right before the dropped beat, what is the PR interval right after the dropped beat, because that's where you'll see your greatest differential. And then you can differentiate whether it is Wenckebach or whether it is type 2 second-degree AV block. And in this situation, here you have a dropped beat again, in this towards the end here as an example, and this PR interval is the same as this PR interval here. They also have a right bundle branch block. So this is a more concerning finding when you start to see this versus Wenckebach. You can have 2-to-1 heart block, and in this situation, it's more difficult to tell. The P waves march out, and it's 2-to-1 conduction. Can't tell which of the two types of second-degree heart block it is. And then you can have complete heart block. So in this situation, you have more P waves than QRS complexes. That's different than the VT we showed before, where there were more QRS complexes than P waves. And there's no relationship here between the P wave and QRS complex. This is one of my favorite EKGs to show, just because there's no relationship, except for every so often you get a beat like this, where actually you have a QRS complex and this P wave is negative. It's different appearing. And that's because the electrical signal is going backwards. So you have no signal going forwards from the atria to the ventricles. It doesn't conduct. But in a weird way, there's this term anisotropic conduction. The electrical signal can still go backwards. And to me, that's just like fascinating, right? That the electrical signal can't go one direction, but it can go the other way. Like, it's super cool. And you can see it in an EKG. EKGs are the most awesome part of cardiology, probably of all of medicine. All right, vagal events. Vagal events are super common in the hospital setting also. All right, you'll have someone on telemetry. Either maybe they're feeling nauseated for some reason, maybe they're sleeping for some reason, maybe they're like getting turned for some reason, or whatever it is, someone has a vagal event. All right, and what you can see here is that they're going along and the P wave rate starts to slow down. Just in case you've never seen this on telemetry, this beat here in gray represents this first next second or two here. All right, so this beat here is the same as this. It's just a duplication. That's a little telemetry secret. So the P wave rate is starting to slow down, and then the PR interval increases, and then you start to get these dropped beats along the way. So this is really consistent with a vagal event. This is not consistent with intrinsic cardiac disease. Okay, this person does not need a pacemaker usually. It'd be pretty unusual we would put a pacemaker for this indication. So the fact that the PP, the P to P rate slows down, the fact that the PR interval lengthens also before you get the drop, those are the things that are making you think that this is a vagal event. So usually for bradycardia in the hospital, what we would say is, for most situations, is the heart rate less than 40 beats a minute? In a hospitalized setting, that's what we're really going to care about. Okay, we're going to care about, is the patient symptomatic or not? Really, the decision for management for a lot of tachycardias, not all, but for a lot, is does the patient, or arrhythmias, excuse me, is the patient symptomatic? And then is it acute or chronic? Right? Like, does the patient chronically run a heart rate of 45 because they're a Tour de France cyclist? Right? And so now they're in the hospital and they have a heart rate of 45 again. Like, who cares? That's their heart rate. And then, were they sleeping? So are they having arrhythmias while they're sleeping? Do they have a history of sleep apnea? And for a lot of arrhythmias, and especially a lot of bradyarrhythmias, even complete heart block, all right, especially while sleeping, may not need treatment. So if I even see complete heart block while someone is sleeping, I leave it alone. And, it's usually like 3 seconds or something like that. They don't need a pacer. They don't need a temporary pacer. Right? It drives me crazy when I hear they're like, oh yeah, this person had 3 seconds of a pause at night and we were really worried. So we checked in on them and we woke the patient up to ask if they felt it and if they were feeling okay. And you're like, oh my gosh, it is so impossible to sleep in the hospital already. Why are we waking our patients up for something that they were sleeping from? Of course they're not having symptoms. They were sleeping. So, especially for bradycardias, if you go in and see that the patient was asleep during it, don't worry about it. Check in with them in the morning. But if you have someone who's symptomatic, all right, in the acute setting, you're going to do transcutaneous pacing, especially if they're significantly symptomatic. But it hurts to get transcutaneously paced, so please sedate them. One of my big pet peeves is do not leave patient pads on a patient just to be safe. You'll put a nursing order in that says atropine at the bedside and leave pads at the patient. Or leave pads on the patient. Don't do that. Number one, because we're not allowed to leave atropine at the bedside in most rooms. because we don't want someone to take it or use it or a family member to do something with it. So you can't do that anyway. And I did a research study with a resident, Dan Nguyen, Ken knows, from several years ago, where we tried to figure out of everybody who got transcutaneously paced in the hospital and then later got a pacemaker, how many times did it look like they had pacer pads on them beforehand? And the answer was 0. So we're never actually using those pads. And then after about 24 hours, they're really irritating to the skin. So don't do that. But you can use dopamine, you can use epinephrine, you can use isoproterenol, but it's really, really, really expensive. If someone has a beta blocker overdose, which you may see once in your training, maybe you can give glucagon as the antidote. We do a lot of transvenous pacers in our world, so that's a little bit more of the definitive, or well, the temporary definitive thing to do. But obviously, you're calling us in that situation. All right. In conclusion, you are going to be called frequently about arrhythmia issues. Some of the big take-home things is get an EKG. All right, if it's sustained enough and if they're stable enough, get an EKG. It's really important. It'll help us manage the patient, helps in the future because I'll look back at EKGs from 2 years earlier to help me out. Look at telemetry yourself. See if you agree with it. It's a good learning opportunity. Talk to the teletechs. They're really smart. They're really good at knowing what's going on. If it's a tachycardia, don't use hemodynamics to make the diagnosis. So don't use your blood pressure to help you figure out what it is. And then in your head, figure out, is it wide complex or narrow complex? Is it regular or irregular? And then figure out what box it's in. For most tachycardias, beta blockers and calcium channel blockers, whether it's PO or IV, they work, and they work pretty well for slowing things down, whether it's coming from the sinus node, whether it's coming from the AV node, whether it's coming from somewhere else, and you want to slow it in one of those locations. If you want to try and convert someone, amiodarone is pretty much our go-to medication in the hospitalized setting for almost everybody for whatever arrhythmia it is, using an IV. But if someone is more unstable, cardioversion, whether it's elective or whether it's more urgent. And if someone is bradycardic, try to figure out where the level of block is. Is it in the sinus node? Is it in the AV node? Is it below the AV node in the His-Purkinje system? And then are they symptomatic? Were they sleeping? And then really, if you're concerned about it, then you want to be calling cardiology for transvenous pacing. So thanks. If you really have any questions, I love EKGs. I hope that's come across here. Really think EKGs are fabulous and fascinating, and you can learn so much from it. So feel free, like if you found a cool EKG, to email it to me or ask me questions about it. Truly, I'm happy to discuss it. I put this QR code up here. I think this is supposed to be for you guys to evaluate me. So please snap that and tell me how I can make this better for future years. I am open to feedback. I have changed it throughout the years in response to this. And thanks for attending. If you guys have questions, I'm happy to take any.
Yeah, thank you so much. That was wonderful. I feel like every year I learn even more. So thank you again. If you guys can do the evaluation, that would be wonderful. And then, yeah, any questions, please feel free to ask.
All right, I will stop sharing. Thank you, thank
Sounds
you, thank you.
good.